So imagine walking into a clinic because the foundation of your home is failing.
Right.
Like the floors are literally sagging beneath you.
Oh, that's terrifying.
Yeah, exactly. And you hire a contractor, and they proudly charge you like $3,000 for a premium coat of waterproof paint on the drywall.
Just pants.
Just paint. And they tell you it looks brand new. The walls feel incredibly smooth. But the underlying joists are still completely snapped.
Which doesn't solve the problem at all.
Right.
Yeah.
But that is essentially what is happening to, honestly, thousands of people worldwide in this rapidly expanding, highly lucrative, and, as we'll see, wildly unregulated space of pelvic health.
Yeah, the gap between cosmetic dermatology and reconstructive urogynecology has just, it's never been wider or, more heavily marketed. And when you're dealing with your pelvic health, confusing a surface-level aesthetic treatment for a biomechanical repair can be physically damaging.
Which is exactly why we are pulling apart this massive stack of sources for you today. Welcome to this deep dive.
Glad to be here.
We are looking at clinical protocols, National Health Service guidelines from the UK, some pretty severe FDA warnings, and we're contrasting all of those directly with these slick, heavily distributed cosmetic brochures.
The kind of stuff you just find sitting in a waiting room.
Yeah, exactly. Brochures for platforms like Empower RF, which include devices like the Morpheus AV and Forma V or the new V CO2 laser.
Right.
And our mission today is to cut through all that marketing noise and answer one very specific, frequently misunderstood question. Can vaginal tightening fix prolapse issues?
It's such a critical question for us to answer because the information you'll encounter out there as a consumer is honestly wildly contradictory.
It really is.
The clinical data says one thing and the commercial health space claims something completely different.
Okay, let's unpack this.
Yeah.
Because if you look at a brochure for one of these laser clinics, it promises like a 30-minute painless fix for prolapse with zero downtime.
Right, you can just go back to work the same day.
Yeah. But then you flip to the regulatory bodies, and the FDA is waving these massive red flags. So to sort the biophysics from the marketing spin, we really need to establish the baseline anatomy here.
We do.
Because we see the terms laxity and prolapse used interchangeably in these brochures all the time.
What's fascinating here is that the root of all this clinical confusion really just comes down to vocabulary.
Oh, interesting.
Yeah, they're treated as the same condition in the marketing, but mechanically. They could not be more different. Vaginal laxity is fundamentally a degradation of the surface tissue.
Okay.
It's that subjective sensation of looseness, which is largely driven by changes in the extracellular matrix of the vaginal mucosa.
And the sources get quite specific about the cellular environment here, right? We aren't just talking about the obvious physical stretching from vaginal childbirth.
No, not at all. That's a big factor, especially if forceps or a vacuum were used.
Right. But we are also looking at a fundamental shift in collagen itself.
Precisely, because as you approach menopause, the steep drop in systemic estrogen completely changes that cellular environment.
So what does that actually do to the tissue?
Well, reduced blood flow to the vaginal mucosa causes the epithelium to just thin out. The elastin fibers begin to fragment, and the ratio of type 3 collagen shifts, meaning you basically lose that bouncy, resilient tissue.
Oh, got it.
You're left with a loss of elasticity, a decrease in natural moisture, and just this overall feeling of reduced support.
So laxity is really an issue with the surface material.
Exactly.
Let's contrast that with pelvic organ prolapse, or POP. What is the actual biomechanical failure happening in a prolapse?
Well, prolapse is a structural collapse. The pelvic organs, so the bladder, the rectum, the uterus, they don't just float in the pelvis.
Right, they have to be held up by something.
Exactly. They're anchored in place by a highly complex, deep suspension system. We're talking about the endopelvic fascia and dense fibrous bands like the uterosacral and cardinal ligaments.
Like a hammock.
Yes, like a hammock. And when those deep ligaments tear, or if they detach from the pelvic sidewall, or just become severely weakened, the organs literally lose their structural support.
Oh.
And they physically drop down into or even protrude outside of the vaginal canal. So you have anterior prolapse with the bladder, posterior with the rectum, or apical with the uterus.
Let's visualize this mechanically for a second.
Yeah.
If my closet is the pelvis, laxity is like a stretched out sweater. Right.
Okay, I like that.
It just doesn't fit the same. The material has changed. But prolapse is when the actual hanger snaps and the clothes fall to the floor.
That's a perfect analogy.
You can't just shrink the sweater to fix a broken hanger.
Yeah.
And I guess I have to ask, is this why tightening treatments might be totally missing the mark for prolapse?
It's exactly why. I mean, chronic constipation, heavy lifting, obesity, those things contribute to both issues.
Right.
But confusing a structural drop, the broken hanger with surface looseness, the stretched sweater, is exactly where these treatment plans just go completely off the rails.
Okay, so now that we know the difference between the stretched sweater and the broken hanger, let's look at these heavily advertised tightening solutions.
The non-surgical energy devices.
Yes, the clinic claims are wild. They're promising these 15 to 30-minute sessions using radio frequency like Forma-V or Thermava, or CO2 lasers like Nu-V.
Right.
And they say it's painless, it heats the tissue, it simulates high-intensity Kegels. I think the V-Tone device claims that one.
Yeah, that's what their literature says.
And they claim it stimulates collagen and tightens the whole canal. Some of these clinics are explicitly marketing these devices for mild to moderate pelvic organ prolapse.
Explicitly marketing it as a fix.
Yeah, they provide support without surgery.
Well, if we connect this to the bigger picture, the reality from the regulatory side is incredibly stark.
Lay it on me.
In the UK, NICE guidance, that's the National Institute for Health and Care Excellence, considers these treatments strictly investigational.
Investigational, meaning not proven.
Right. And the US FDA has gone even further. They've issued severe safety warnings.
About what, exactly?
About deep burns, severe scarring, and chronic pain from using these energy devices for so-called vaginal rejuvenation.
Oh, my God.
And most shockingly, Australia's Therapeutic Goods Administration actually canceled all approvals for these exact devices for gynecological use.
Right, really?
Yes, effective in 2025. They reviewed the global data and decided the risk profile and the lack of evidence that it actually treats things like prolapse meant they had to pull them from the market.
Okay, here's where it gets really interesting to me.
Yeah.
If the FDA and NICE are issuing these massive warnings and Australia is literally banning them, how are clinics still legally claiming these lasers fix prolapse? Like, how is that allowed?
Well, it comes down to the massive gap between aesthetic medicine and reconstructive urogynecology.
Okay, explain that.
So impartially speaking, we have to acknowledge that these devices might improve some things. They might improve surface comfort or moisture, or even create a subjective feeling of tightness.
Because they're causing that microtrauma and making some new collagen on the surface.
Yeah, exactly. They are treating laxity. The problem is, they absolutely do not tighten the structural ligaments enough to lift a fallen organ.
Right, they just don't go deep enough.
The energy penetrates maybe 3 to 5 millimeters. The broken ligaments causing the prolapse are centimeters deep.
Wow.
You physically cannot reach that structural scaffolding with a laser without burning completely through the vaginal wall. We aren't taking sides on whether people should get cosmetic procedures, but the clinical data simply does not support lasers as a structural fix for prolapse.
Okay, so they're repaving the asphalt on the bridge and telling you the snap suspension cables are totally fine.
Exactly.
So if expensive laser tightening isn't the cure for a structural prolapse, what actually works? Like, what does the evidence-based medical management look like?
Well, the clinical guidelines require a conservative first approach.
Which I assume doesn't just mean doing a few Kegels at a stoplight.
No, far from it. It requires supervised pelvic floor muscle training, or PFMT. Yes, usually guided by a specialist physiotherapist. And it's intensive. We're talking a minimum of 16 weeks of progressive training.
So you're literally strength training the pelvic floor.
Exactly. You are trying to build the physical mass of the levator ani muscles to create a muscular shelf. Because the organs can't hang from the ligaments anymore, they need to rest on that shelf.
That makes total sense. And the sources also talked about lifestyle modifications, right?
Yes. You have to stop the downward pressure that caused the collapse in the first place.
Right. So things like losing weight, treating chronic coughs, managing constipation.
Precisely. You have to stop pushing the organs down.
Okay, but what if you do all of that and the organs are still dropping? There was this fascinating non-surgical mechanical fix in the sources that I really want to talk about.
The pessary.
Yes.
Yeah.
The vaginal pessary. For anyone listening who doesn't know, it's this silicone device fitted into the vagina to physically hold the organs up.
It's an incredibly effective intervention.
It's literally like putting a temporary support beam under a sagging roof. And the research from Dr. Marcus Carey was amazing. He found that 3 out of 5 women successfully fitted with a pessary use it beyond 1 year.
Yeah, the adherence rates are great. For many patients, it completely neutralizes their symptoms without ever needing an operating room.
That's incredible.
Yeah.
But obviously, sometimes surgery is needed.
Yes, when conservative management and pessaries fail, surgery is the next step. But we have to be very clear here.
Right.
We are not talking about cosmetic vaginoplasty, which basically just narrows the canal. We are talking about structural reconstruction.
Okay, what does that actually look like?
Take a colporrhaphy, for instance. This repairs the wall between the vagina and the bladder or rectum. The surgeon dissects through the vaginal wall to reach the deep fascia and physically folds and sutures it to rebuild the structural wall.
Oh, wow. So they are really getting in there and rebuilding the scaffolding.
Yes, and for an apical prolapse where the whole vault has dropped, they do a sacrocolpopexy.
I remember reading about that one.
It's major. They attach the vaginal vault directly to the spine using a mesh or graft.
They literally bolted to the spine.
Essentially, yes, to the strongest anchor point in the pelvis. And then there are obliterative procedures, like colpoclysis.
Right, which is for people who no longer desire penetrative intercourse, right?
Correct. The surgeon physically closes the vaginal canal. It provides almost immediate relief because the organs simply have nowhere to drop into.
So what does this all mean for the listener? I mean, if someone out there is feeling that dragging sensation, should they just completely ignore these laser tightening procedures?
Well, it's about matching the tool to the problem. Tightening procedures, like careful radiofrequency, they actually have high satisfaction rates for treating laxity and improving sexual function.
Okay.
But they are entirely the wrong tool for prolapse. If you feel a bulge or a dragging sensation, you need a urogynecologist to diagnose the structural issue first.
Right. So the core takeaway here is that vaginal tightening can address the sensation of looseness, but it absolutely cannot mechanically lift a fallen pelvic organ.
Exactly. And recognizing that difference protects your health and, honestly, your wallet.
Absolutely. Though, this whole discussion raises an important question for me.
Oh, what's that?
Well, the sources briefly mentioned that a strong family history of prolapse points to an inherited weaker collagen type.
Right, like some people are just genetically predisposed to have those ligaments fail.
Exactly.
Yeah.
So if prolapse is deeply tied to our genetic collagen blueprint,
Yeah.
could the future of pelvic health move away from mechanical fixes entirely?
Oh, wow.
Like instead of meshes or lasers or bolting things to the spine, what if we focused on genetic or cellular therapies?
To fundamentally alter the tissue's resilience before prolapse ever happens.
Yes. Treating the cellular failure before the structural collapse.
That is wild. I mean, treating the genetic blueprint instead of just constantly repaving the asphalt or rebuilding the bridge.
It's a huge paradigm shift to think about.
It really is something to mull over. Well, thank you so much to everyone for joining us on this deep dive.
It's been a great conversation. Keep asking questions about the biophysics of what you're being sold, demand rigorous clinical evidence, and always remember to check the structural cables before you pay for a new coat of paint. We'll catch you next time.